2000, terrific, the 2026 Maura Whitehead Lecture. A few words about Maura. Maura Whitehead was a pediatric resident here at Children's Hospital of Pittsburgh from 1984 to 1987, and she was just a wonderful human, smart, dedicated, warm, and compassionate. Maura was particularly interested in the care of children with a variety of psychosocial challenges, especially children living in poverty, and was really the inspiration for the development of our SCORE program, which continues in its 23rd year, I believe now, focused on leadership, advocacy, and service to the underserved. After graduation, Maura served as the pediatric chief resident at Mercy Hospital. And in its time, that really was the safety net hospital for our children here in the city. Maura, her interest in in community health and care for the underserved continued to flourish there. She died unexpectedly midway through her chief year, leaving her husband, Peter, and her young son, Alec, and her family devastated by the sudden loss of this young, spirited woman and promising physician. Maura's family, friends, and colleagues established this annual lectureship in her memory, intended to educate, stimulate, and motivate the medical community to consider issues that would have reflected her sensibilities and concerns. Previous Whitehead lecturers have considered the medical problems associated with poverty, public policy and how we can impact them as pediatricians, bioethic issues, and other similar topics. It's really an incredible list of prior lecturers, and today will be no exception and a new addition to that list. Dr. Peter Thorne, Maura's husband, is here with us today. He has attended and given the lecture twice, but he has attended 31 of the 32 Maura Whitehead lectures, and it's always a real treasure to see him here in Pittsburgh for a day or so. He has helped to see the Whitehead Endowment come alive and always wanted to see it used for something that Maura was passionate about, bringing community interests together. So we've been able to expand out the mission of the Maura Whitehead Fund, and this year sent a call out to residents to encourage them to apply for grants to help community-based child health initiatives. We are pleased to be able to fund 2 resident awards, and I'd like to congratulate Doctors Anthony Tyrone, Hutchinson, and Sedantrum for their project of Let's Grow, a community garden and family education, as well as Doctors Fontaine and Hermson and Ferrer for their project in heat illness in sports for young athletes. These are the first 2 Maura Whitehead Endowment grants in community projects, and we are excited to hear how the projects go this year, and we look forward to them reporting back to us. Congratulations to both of those teams. I'm excited to introduce our speaker today, Dr. Deena Chisolm, and she is the Nationwide Foundation Endowed Chair in Health Equity and Research and a professor of pediatrics and public health at The Ohio State University. She serves as the director of the Center for Child Health Equity and Outcomes Research in the Abigail Wexner Research Institute at Nationwide Children's Hospital. Dr. Chisolm's research focuses on improving health and healthcare for children and families, particularly those from the minoritized and socially disadvantaged populations. She has over 130 peer-reviewed publications and nearly 20 years of continuous federal grant funding. Her current projects explore how healthcare delivery systems, health policies, and social drivers of health influence healthcare access and health outcomes. Dr. Chisolm prioritizes bringing her research findings and her methodological expertise into the community and government sectors. This has included being appointed to serve on the CMS Federal Advisory Council on Outreach and Education and the governor's COVID-19 strike force. She is the former chairman of the Ohio Commission on Minority Health Board and serves as the board chairman of the Health Policy Institute of Ohio Board and the president of the Columbus Board of Health. I'm so looking forward to learning from her for the next hour. Welcome, Dr. Chisolm.
Good morning, everyone. I've got most of my cup of coffee in me, so there is a chance that I'll be able to get through this in one piece. First of all, I would just love to thank everyone who was part of the decision to invite me to give this talk. I got a chance to read a little bit about Moira Whitehead before I came. I got a chance to spend a nice dinner with Peter and so many people who understand what she's brought to this institution and what her legacy continues to do in this organization. And I'm just honored to be part of that legacy and be added to that list. I am going to talk to you a little bit today. It's not really going to be a traditional research talk, but it is going to be a talk about sort of where we are in the world of health services research, particularly research that focuses on populations that have specific needs. And knowing where we are, how do we keep doing what we're doing? What we're doing, what we should be doing, what we have been doing. So a lot of what we've run into, let me make sure I know what I'm doing here. There we go. So I know here in Pennsylvania, much like Ohio, there have been some backlash to some of the terms that we've used to describe health equity research. And I think I'm allowed to say that. They told me I could say that. But if I get the hook, I'll know what happened. But whether we can say those words or not, we still have to do that work. And that's what I really want to talk about today. So I don't have any disclosures I want to report. But I do want to say what I mean when I talk about health equity work, because lots of people have different thoughts about what we mean when we say health equity work. And for me, it's really these three simple points. It's that every child has the opportunity to achieve their best health. It doesn't matter where they were born. It doesn't matter how much melanin they're carrying. It doesn't matter what their primary language is. Every child has the opportunity for their best health. That their health is not determined by who they are or where they live. And most importantly, that systems that don't support those first two goals are either fixed or destroyed. And I'm willing to say some of those things out loud. We need to figure out what are the systems, the policies, the ideologies that are keeping us from reaching those goals and fix them or remove them. And that's the only way we're going to get to where we want to be. So, probably 3, 4, 5 years ago, more than that, I spent a lot of time talking about health services research, about learning health systems, about healthcare quality research. And a lot of folks would bring me in to talk about how you integrate a health equity lens into that work and the importance of including a health equity lens when you're doing quality improvement projects and other improvement activities. And I had a whole spiel, and it was really great, and it said all the things I wanted to say. And so those previous talks, those previous slides really centered on three things. One, that you can't be colorblind and care about health equity. And I had a whole series of slides, which I'm not going to show you today, about all these times you can look at something in the aggregate and it looks fine. And then you disaggregate it and you realize, ooh, that is the opposite of fine. And that simple truth was rooted in the statement, you can't solve a problem you can't measure. So if you can't see the problem, you're not going to solve it. So can't be colorblind and care about health equity. The second thing was that universal precautions will never yield universal results. So a lot of times we would talk to people and they'd say, well, we're doing a standardization across this practice guideline, and so we don't have to worry about health equity, or we don't have to worry about bias because we're going to use this one thing that's going to work for everybody. And, spend a lot of time talking to folks about the fact that, the whole concept of a rising tide lifts all boats doesn't work when some people are in a yacht and some people are in a dinghy with a hole in it. So we need to really think about how do we do the right thing for the right people. And that the third simple truth was that the hardest conversations are the ones that matter most. So the being willing and able to be in a room where somebody's putting forth a project and say, Hey, did we think about how this is going to impact the rural population? Hey, did we think about how this is going to impact the uninsured population? Being willing to step out and say, this is a nice idea, but we need to think about it more broadly. And talked a lot about how we get more people to be willing to be the voice that says that, so that it doesn't always fall on one person or one group of people who end up being painted with a brush of the person who always brings this up. And to the point of, I said, maybe you just have one person or you have a circle, and like every meeting is like, okay, you. Okay, I'm in charge of saying, did we think about a population? But everybody has to do it once in a meeting. But anyway, the point is, this was the talk. It was a great talk. People loved it. But things change. So now, on today's episode of Dr. Deena Talks About Health Equity, our truths change a little. So we say you can't be colorblind and care about equity, but our unsimple reality that we're in now is that the data to measure health equity is increasingly less available. The variables are being pulled out of some of our databases. We're given specific rules that we can't even collect those variables in our research. The funding to collect the data that we need to answer these questions is starting to dry up, and our ability to communicate the findings is being increasingly censored in the spaces where we're trying to present it. The second truth, that universal precautions will never yield universal results, is turning into this reality that targeted interventions are being classified as DEI, and the consequences for doing such can be consequential or substantial. So we in the state of Ohio, like I said, I work for the one of the things I do in my spare time is serve on the Board of Health. And we got a letter from the federal government that said, if you have one DEI program in any institute or any agency in your city, we are going to take all of your federal funding from the city. So, of course, health is one of those places that had a lot of things that focused on specific populations because we're dealing with HIV/AIDS and we're dealing with violence prevention. We're dealing with a lot of things. And so we had to go back through and figure out, how do we make sure that one thing that we do doesn't defund the police because it's the same bucket of money. So the things that we used to think were important to do targeted work are harder. And the third simple truth is that those hard conversations are even harder, and the consequences are even weightier. We know people are losing their jobs. We know people are losing their grants. We know people are walking away from the work because of the discomfort that the current situation is putting them in. So as much as I want to, give my old talk, I have to root it in a new talk. But I also want to say it's not all bad. Even though the ways we talked and the ways we did things are being changed, the guidance we're actually officially getting from some of the folks in the feds make it sound like and allow us a fair amount of latitude. So, instead of using umbrella terms like non-white or people of color, they're encouraging folks to use precise language to define your population that you're studying and your comparator groups. They're encouraging us to use specific measurable constructs like redlining or restrictive covenants, as opposed to saying systemic racism. And they really want us to focus more on prioritizing research and activity that changes disparities, doesn't just identify disparities. And some of those are things that a lot of us have been saying for a while. We said them in a different tone. We said them in a tone that said, here's how we can get better, not stop what you're doing. But they're still not necessarily bad things to say. We've heard that, they want us to avoid words that are linked to ideology like equity, gender, and diversity, to avoid framing questions in ways that blame society or structures, and they want us to align our proposals with NIH priorities. So these are all the things that we're hearing. And for some folks, it's feeling really heavy. It's feeling like this is what I spent, the past 8 years going through training for is to do exactly these things that you're saying you don't want me to do. And this is the vision that I had for my career that was going to get me through tenure. And now you're telling me I can't do that. And I'm feeling lost. I'm feeling at sea in my science and in my professional life and my goals. And what I want to say today, and what I'm going to say in my slides, is it's okay. We can still do all of these things, even if they take our words, because we have tools that work regardless of what words that we use. And so I want to start with a story to illustrate why I say that. So I'm from Springfield, Ohio. Now, some of you may have heard of Springfield, Ohio in the last year or two because it's become a hot button city in the political environment. So it was questions about dogs and cats during the election, and now about trying to remove about a third of the population that fall into categories under temporary protected status. So Springfield is much more famous in the past couple of years than it has been. It is an old school manufacturing town that built its reputation on building trucks with International Harvester and brooms with Vining Broom, and had a big casket factory, none of which are operating at the level they were in the 50s, 60s, 70s. So it's a town that's on the downswing in a lot of ways. But it's also a town that has a lot of history and has a lot of old stuff. This is the church where I got married. I don't know if you can see you can't see my thing. Okay, so you can't see that there's a church where I got married. But if you look at the very bottom right of your screen, you'll see a little car driving over a little railroad track. And that's what I want to talk about. I'm going to talk about that car that's sitting on that railroad track. And the reason I want to talk about it is that that railroad track crosses the entire city. You cannot get anywhere in the city of Columbus without driving over that railroad track. Why does that matter? Because if you look here, you can see the railroad track running across the middle of the town. And those two red circles represent the two hospitals that used to be in Springfield. Both of those hospitals are north of that railroad track. And then later they closed those two hospitals, decided we only needed one hospital. And guess what? They built that one hospital on the north side of those tracks. So those tracks served as a structural impediment to anybody on the south side of town who needed health care. There were a whole bunch of babies born on the wrong side of the tracks. There were heart attacks on the wrong side of the tracks. There were strokes on the wrong side of the tracks because there were trains all the time. They were long trains, and there was literally no way to get around. Now you can say, well, yeah, but that's something that impacts everybody, right? And I would say yes and no, because it does create a potential health inequity, because this is a image of the Child Opportunity Index. So lighter colors represent lower opportunity, so areas that have less income, less employment, less resources. And you can see the Community and Mercy Hospitals, the original two hospitals on the north side of town, that has a little more darkness, which means a little more resources in this situation, compared to the south side, which is where I grew up, that is pretty much all very low. So now you have all your very low people living on the south side of town, which is on the wrong side of the tracks, which is not where you can get health care. So what do we do about it? And the answer was build an overpass. Build a path over the structural barrier to health. So this is a picture of the town, and you can see where that little one is. That is the old Union Station that was built in 2010. And in 1969, so just a couple of years after me, they tore that down and they built an overpass. And that overpass created a path to healthcare for everybody living on the south side of town to not have to sit behind that train and deal with the health issues of that. And this is the shots today from Google Maps. You can see the train track and the bridge over it in the distance, and you can see a flyover of driving over that overpass. So you're wondering, what in the world is this woman talking about, and why is she talking about this train and this overpass? The reason I want to start with that story is that the moral is health inequities can be caused and addressed by systems that have nothing to do with healthcare. So to the extent that we are working in the healthcare system and we say healthcare is having its hands tied, reminder, healthcare is not always the cause or the solution of the things that we need to focus on. That a structural solution, like an overpass, a really big bridge, can yield lasting results in ways that sometimes short-term fixes can't. Reminding us that sometimes the problem isn't being from the wrong side of the tracks. The problem is the tracks themselves. And being able to keep in our mind, it's not that those people on the south side were having those babies outside the hospital and that's why those babies were having bad outcomes. It's we have a structural barrier that's making that happen. It's not them, it's the tracks. And that really changes the way you think about the populations you serve. And the last thing is they addressed a health inequity without ever using the word inequity. No one had to go through a grant and delete the word inequity every time it appeared in their specific aims page. Nobody had to edit their slides to take that word out. But they still did a meaningful solution to a big equity problem. We still have the tools to do this, even if we don't have the words. So what I'm going to talk about the rest of the time is how do health systems and health services researchers work to improve health equity when equity is kind of a bad word, and when you're sitting there just angry that you can't write what you want to write when you want to write it, or tell the stories you want to tell in the way you want to tell them. And I'm going to talk about three tools, three methods for doing that. And one I'm going to use some national data for. And the other two, I'm going to share some specific research that is coming out of my team. So three models for, and this actually says learning health systems, but anybody who's doing work in this space around inequity. We're going to talk about unnecessary variation. We're going to talk about targeted universalism, and we're going to talk about precision population health. So we'll start with targeted universalism. So target universalism is this idea of setting universal goals and pursuing targeted processes to achieve those goals. The big concept around targeted universalism is that rather than comparing populations, which always makes one population feel less than and one population feel blamed or feel held responsible for something that there isn't their fault and makes them defensive. That's what happens when you compare two people. How do we change our model, change our mindset so we're not comparing two groups in a way that creates dissent? So the model I'm going to use for this is data from Healthy People 2030, and looking at treatment for major depressive episodes in adolescents and whether or not they get follow-up treatment in 12 months after a major depressive episode. And so this is data from 2021, so some of their baseline data. So we start with the baseline data. We say, okay, there's opportunity for improvement. And that opportunity improvement is higher in some groups than others. How do we do this today? Today, we would be tempted, or in the past, we would have been tempted to really start with the statement, the treatment rate is 25% lower in the poorest group than in the wealthiest group. That would be the headline that we would put on the paper or on the presentation. And that would lead people to say, we need to do better about what's happening in the poorest group because, they deserve to have as much as the wealthy group does. And there's nothing wrong with any of those statements, except that they don't fall on ears the same way they used to. So the vision for targeted universalism is its 5 steps, and you can find all the information about it at the Targeted Universalism website. It was created by John Powell, who was the founding director of the Kirwan Institute at Nationwide Children's Hospital, which is Center for Study of Race and Ethnicity. But anyway, you've got 5 steps. You set a universal goal. And then you assess your population relative to that goal. And then you say, is everybody performing at the same level on that goal? If not, what's causing everybody not to perform at the same level on that goal? And then ultimately, how do we change that? So it's a pretty easy step-by-step process. So you take that slide that I had before. First of all, we said overall the population, the success rate in our measure was 40%. We don't have a real clinically driven goal, so we're just going to say we're going to improve it by about 10%. So this is what the federal government did when they set their target in Healthy People 2030 for this measure. So step 1 is measure the whole population and set a target goal, steps 1 and 2. Step 3 is to compare population groups to that goal. And so when you do that, you're not comparing the population groups to each other, you're comparing them to the goal. And now you say, okay, so we have, our wealthiest group is, just barely tipping over the edge. So yay, that they're there, but they could also do better. But what's going on in that group that's allowing them to be over the top? And then you look at the other groups and say, how far are they from the goal? Not how far are they from the wealthy group, but how far are they from the goal? And even though it sounds like it's just a tiny little difference in the way you're saying it, the way that it falls on people's ears, the way that it doesn't trigger defensiveness, makes it possible to have a communication, have a conversation. And then you do work, you follow the data, and you see, instead of worrying about did this group get better in comparison to the other group, you worry about did they get better in comparison to the goal? And then you can say who got way better in comparison to the goal, who got better but didn't get to the goal, what different things happened in different groups that allowed people to get closer to the goal. So again, you have a opportunity to discuss things. The idea with targeted universalism is that we do intervene with everybody. So we have some universal intervention, which I said doesn't work for everybody, but you start with some universal intervention. And then you build on that for interventions that are specific to the specific population's reasons for not being at goal. And it allows you to say, no, we're not only spending money in this population and not spending money in another population. We're spending money everywhere. We're just spending it differently in the ways that are most likely to generate the best results. So I had an opportunity to talk with the Agency for Children and Youth in DC, and they had said, we want targeted universalism to be the way we approach everything so that we don't have to talk about equity. And, part of that hurt my heart because I love talking about equity. But the fact that they still wanted to do it and find ways to talk of it made me feel good. And so you have to get your wins where you get them. So that's one way that we can still do the exact same work, just choosing to take a slightly different model towards it. Next one I'm going to talk about is addressing unnecessary variation. So many of you who have been around these fields for a while or remember the Dartmouth Atlas. So back in the 90s, late 80s, early 90s, there was a whole lot of work done around why is healthcare different in different places? Why do people who live in this state get knee replacements and people in this state never get knee replacements for the exact same presentation? And people spent a lot of time figuring out how do we deal with this unnecessary variation. Again, this was not ever couched in terms of health equity. It was not couched in terms of inequities or structural racism or any of those things. It was just why do things happen differently in different places? we can pick up that tool again and continue to use it in the ways that we're doing this work. And for that, I share this picture. This is Columbus. And this are rates of preterm birth by zip code in Columbus. So one of the projects we have going on right now that's funded by the National Institutes on Child Health and Human Development is focused on just this question. How do we deal with infant mortality, which is a intransigent, just won't get better situation in a lot of our communities. In Ohio, particularly, we're in the bottom 10 in infant mortality in the country and in the bottom 5 in infant mortality disparities, with a Black baby being 3 times more likely to die than that same white baby in our city, which is not okay. And so our grant was really focused on the idea that we can see that this outcome is not distributed equally around our city. So what is it about these spaces, as opposed to the people in those spaces, that allow us to focus on making a change and doing something different? So our project is happening right here in 43211, which is a community that's called Linden. And what we're doing with that is a historic evaluation of policies that have put the neighborhood where it is today. So those are policies like redlining. Those are policies like restrictive covenants. Those are policies like transportation policies around where highways have been placed and impacted the community, around school funding and school placements. So we wrote a poll paper that was published in Health Affairs that talked about what has happened in the past 100 years in the Linden community that has made it the under-invested space that it is now. Because and then alongside that, we also have done interviews with women who have given birth and raised children in that community over the past 50 years and asked them, how does the space that you live in impact your pregnancy experience and your parenting experience? So we've put together this historical evaluation and this qualitative interview data to say, what would it take to undo what's been done to this community? So there's a lot that goes on around community investment and people buying up spaces and fixing them up and making the neighborhood pretty and all these things. It's like, that's great. But what if we took that investment and didn't just make things pretty, but made things better? What if we didn't just make things better, but made them better in a way that addresses the fact that they were intentionally made worse? And what if we help the people who are making those decisions about those dollars understand what those dollars are bringing to the table beyond increased property values? So right now we are in the process of bringing together the community to look at everything that we've learned from our policy inventory and our qualitative data, to do a group model building approach and to create a structural diagram that explains how all these things come together. And then we're going to take all that and we're going to sit in a room with all those big dollar people and say, we want you to keep putting money into the community. We want you to put this money into the community in a way that is focused on the population that has been disinvested in and the space that has been disinvested in. Again, my goal in my head is reducing racial disparities in infant mortality. This project, which was originally funded as a research project to reduce structural racism, but we had to stop saying that when things changed. But we can do the project. We can keep doing the project. We can without the words. Because what we're doing is understanding policy, understanding history, understanding geography, understanding money, understanding how people bring money to tables. And you can have all those discussions and get to the goal that you want if you want to. The third project I'm going to talk about real quickly is this idea of precision population health. This idea that People talk a lot about precision medicine and this idea that you can personalize medicine for people based on their genes and their environments and their lifestyles. Precision population health, though, takes into account differences at population levels, environments and lifestyles, and really figures out how do you target a population in a way that takes into account why they have what the concerns that they have. So one of the projects we're working on is the Integrated Care for Kids Award, which is a CMMI-funded demonstration project designed to look at how we use Medicaid to address needs of kids who are at high risk of out-of-home placement. And that out-of-home placement could be foster care, juvenile justice, residential substance treatment, long-term inpatient stays. But I say, how do we identify kids, not based on who they are, but based on the risk factors that they have? And then how do we address the needs of those kids and their families and their siblings, and most importantly, their communities in a way that is customized to their spaces, their places, and their risks? So the Integrated Care for Kids model is designed to test an alternative payment model supporting integrated delivery of child services to reduce costs and improve quality of care. This slide has a lot of stuff on it, but the key components are doing population level needs assessment and risk stratification. So starting at the level of 2 rural counties in Ohio, we've combined data from Medicaid and from child welfare and from SNAP and from the Child Opportunity Index and from USDA food deserts and a bunch of other systems to be able to, for each child in the system, figure out what their level of risk is for our outcome. And then we stratify them into one of 3 levels, and this says SIL, that's service integration level. So 1 being the people who don't have any risks, but they're still living in a space that creates an opportunity for improvement. So we're not doing anything fancy at the individual level, but we're doing work at the community level. We're partnering with the schools, we're partnering with childcare centers, we're partnering with neighborhood beautification to do things at the low-risk population but high-risk community level. And then for the people who have primarily clinical concerns, we do sort of traditional care coordination. And for the people who have high social needs that are likely to have them placed out of the home, we do a whole advanced care planning team approach. And ultimately, we build a ecosystem around each family that takes into account food and housing and justice system engagement and education and parental employment and mobile crisis response to create customized services that meet each person, family, and community where they are. This is a approach to doing the kind of work that is going to close gaps. And that's the thing. We want to do the work that closes gaps. And these are the types of tools and types of projects that allow that to happen. So 3 approaches that allow you to do health equity work without ever using the term health equity. So with that being said, rather than being disappointed in our ability to do what we thought we were going to be doing, what can we be busy doing anyway? And that's where we want to be. What can we get busy doing anyway that will keep us from sort of the sometimes depression, sometimes, not great feelings about where we are and why we're here. But if we're busy working, we don't have time to feel bad. So what can we do? We can work on conceptualizing and validating measures of social needs and social barriers. So if the folks in DC are saying, we don't want you to use these broad umbrella terms, fine. We'll create really precise measures that aren't broad umbrella terms. We have plenty of ability to create and validate measures. We can spend time testing clinical, social, and technical interventions that are designed to address those specific measures that we talked about. We can spend a lot of time looking at the role of payment models. We know that there's a whole lot of money in the healthcare system, and we know that it's not always used in the way that maximizes health for all populations. We can do good old-fashioned health policy, health payment model research in a way that is designed to close gaps. We can look at building the data systems that allow us to measure across settings and systems and sectors, because one of the things we know for sure is just trying to do stuff with the healthcare dollar, just trying to do stuff with an NIH dollar isn't going to work anymore. Those dollars are different to come by, sometimes difficult to come by. We've got to get used to figuring out how do we do things across systems and across funding. We've got to get busy mentoring the next generation of clinicians and researchers, helping them to know your career path has not hit a brick wall. There may feel like there's a brick wall in front of you, but all walls can get doors. You just have to figure out how to get the door, and some people will go at that wall with a sledgehammer and they will say, I am going to break this wall down and get through it. Other people will say, maybe if I look hard enough, I can find a little side door in the corner and I can sneak through. Some people will tunnel under or jump over. What we need to do is help our junior faculty and our trainees know you can do all those things and more. Do not let that wall be the barrier to you doing what it is you always hope to do. Leveraging new partnerships and sources of finance. I'm actually having meetings with billionaires because I want them to put their money into our community engaged work. Some of them aren't even my favorite billionaires. Okay, I don't have a favorite billionaire, but ultimately, if I can put money that may not have come from a great place to great work, I'm going to be okay with that. So getting to the point that we're trying to think about differently about how we fund this work. Making sure that we as clinicians, as researchers, are being an ally in population-driven advocacy. We will do advocacy from our seats, but it's just as important that we support the folks in the communities, in the populations, in the spaces to be their own voice, as opposed to trying to be a voice for them. And enhancing the self-efficacy of our patients, our families, and our communities. How do we help people help themselves? Because we don't have the kind of safety net that we used to have. And we don't know when or if it's going to come back. And with that in mind, communities are going to have to start supporting one another in new ways. People and families are going to have to support each other in new ways. And those of us who are blessed to have a different set of challenges have the opportunity to help each community, help people find ways to build new connections that allow them to take care of one another. So for now, even with word limitations, there's nobody stopping us from saying really loud that we are working towards the best outcomes for all children. We can say that in every room that we stand in. That we're focused on reducing unnecessary variation in treatment outcomes, that we're studying person-centered precision medicine so that the right interventions get to the right patients at the right time, and that we're striving to reduce healthcare costs by reducing the need for high-cost services through preventive approaches. Every one of those statements can safely be stated in the vast majority of rooms that we're in. And we might also whisper that no matter how we say it, health equity is our ultimate goal, and that we are still working no matter how many roadblocks are placed in our way, and that we will succeed. Thank you.